Yeah, good morning, everyone. And this is our second session on the NABH accreditation topic. So today we are going to look at the different chapters of NABH and how the chapters are structured. So yesterday I had mentioned to you that there are different standards for different levels of hospitals. I told you that there are small healthcare organizations and there are healthcare organizations. So SCHO and HCO. Uh, these chapters remain the same for both varieties of organizations, whereas the standards and the objective elements within these chapters, they vary for both the SHCO as well as the HCO. Okay. So I'm going to run you through these different chapters. These are the 10 chapters of NABH. The first one being access, assessment, and continuity of care. The second is care of patients. Third is management of medication, MOM. Patient rights and education, that's PRE. Infection prevention and control, that's IPC. Patient safety and quality improvement, that's PSQ. Responsibilities of management, that's ROM. Facility management and safety, that's FMS. Human resource management, that's HRM. And information management system, that is IMS. Okay. So before I run you through each of these chapters, see, it's quite not possible for us to look at each and every standard therein because there are so many standards. However, it will be possible for us to understand the intent and the gist of each of these chapters. Okay. So before I take you through that, I would just like you to have a look at how the standards book appears. Okay, so let me just share that with you. Okay, so this is how the standards book looks, and this is the latest sixth edition for full accreditation standards. This is the last level of accreditation. And if you can see here, I just want you to see two different things. So one is these different chapters which are here. And within the chapters, how the standards are organized, that's something I want you to see. So, yes. So if you look at this, this is the first chapter, and you can see some kind of color coding over here, right? So what are these color codes? You can see four different color codes here. This one is core, this is commitment, this is achievement and excellence. So what NABH has basically done is that they have divided the different standards. So for example, this AAC2, this is a standard which is highlighted within a box. Okay, this is a standard. So this is AAC1. And these in small letters A, B, C, D, these are objective elements. So within a standard, I'm sorry, within a standard, you have objective elements. Okay. So if you can see this color coding, it basically indicates that this core means a core standard. So without that, you're not getting through this AAC2. That means you're not implementing this AAC2 standard if you don't have this core element. Okay, so this is mandatory. Commitment is the next level after core, but then this is also expected for the first accreditation cycle itself. So for the first accreditation cycle, we expect these two standards to be present. Okay. So when you're marking the hospital or scoring the hospital for a particular standard and objective element, we generally try to score it in such a way that it is, processes are in place, and they are fully implemented, or processes are in place, they are partially implemented, processes are in place and they're not implemented at all, or they are fully implemented. So, that way we generally score the hospitals. Whereas this core and commitment has to be present. This and this, that is the achievement and the excellence. The achievement could be for the next accreditation cycle, and excellence could be for the further forthcoming accreditation cycles. See, please remember, each of these cycles go through about 3 years. The first cycle, uh, there is an intermittent surveillance audit which comes up after about 1.5 years. And then there is a repeat audit or a re-audit that comes up after 3 years. Okay, this is for the full accreditation. For the entry level, it comes up every 2 years. Okay, so when the audit comes up for the first time, we look at whether these two standards are fulfilled. When the audit comes for the second time, then the hospital also has something to look forward to, right? And something to step the bar up. So, from in those terms, it is achievement. You can reach the achievement standard. So, if you see here, these are achievement standards. Some of them which are colored green, see this will be excellence standards, excellence objective elements rather. So within each standard, now this particular standard, if you see AAC4, has red also, which is core element, which is absolutely mandatory. So here, A, B, C, and D, all these 4 objective elements will be mandatory for the first assessment, and E as well. This can go on for the second assessment, and this can go on for the third assessment. So you keep stepping up the bar and raising the benchmark so that quality can be constantly improved. So that's the whole purpose of keeping this color coding. All right. Now, having said this, there are different guideline books for different um, levels. Like for entry level, there are different guideline books. For small healthcare organization, there are different standard books, because as I said, the number of standards and the number of objective elements are going to be less, and they're going to be different. So the different books are available. There are different books available for Ayush, for NABL, for wellness centers, for Panchakarma centers. So many varieties of them are available online for purchase. Now I'll move on to the different chapters, the standards, and the objective elements. As I said, it's not going to be really possible for us to look at each of these 680 odd objective elements, but I'm going to give you the summary or the gist of what each of these chapters talks about. So the first chapter is access, assessment, and continuity of care, which basically gives us an idea from the name of the standard itself or the name of the chapter itself. You can make out that access, assessment, and continuity refers to how a patient can access the hospital, how assessment of a patient is supposed to be done, and how do you continue care further on, right? So that's the gist of it. So having said that, what would these standards and objective elements relate to? They would relate to these highlighting points. The first is it talks about the scope of services. So NABH has a particular part in the application form where it asks you for which scope of services you want to avail of the accreditation facility. Okay, so supposing your hospital has, say, 5 services, let's say that all the general specialties like internal medicine, general surgery, and then maybe obstetric and gynecology, pediatrics, okay, orthopedics, maybe these are the services that you offer. So those scope of services will have to be defined, displayed, and made known to the public, as well as while putting it on your application, you'll have to ask for accreditation under those scope of services. Okay, so this is what the first standard says. Then it talks about the registration process and the admission process. So every patient coming to the hospital has to get registered. There is a unique hospital ID which is generated during this registration process. And then the patient either goes away after an OPD checkup or he ends up getting admitted. Now, if he gets admitted, there could be either admission on the wards or there could be an ICU admission, right? Either of these two could be possible. So, based on that, NABH wants us to define the criteria for admission into the ICU. Which are the cases where ICU admission would be necessary? Which are the cases where ward admission would be necessary? How would you define this? How would you allocate a particular patient to a particular ward, and so on? Okay, so all that comes under the admission process. It's more of a clinical criteria over there that we're looking at. Then comes the discharge process. So once the patient is admitted, there are different kinds of patients which are admitted. There are even medical legal cases which we admit. So the admission process for them may be slightly different, wherein you're trying to inform the, police station. You're trying to register the case as an MLC within the police station, and then you're trying to admit the patient. Same at the time of discharge, you might have a different kinds of discharge, right? One of them would be the routine discharge, which every patient goes out at the end of the duration of admission. Sometimes there could be a discharge which is against medical advice. So for whatever reasons, maybe the patient wants to move to another hospital, or the patient wants to, doesn't like the treatment in this hospital and he just wants to take a discharge or something like that. So that could be a discharge against medical advice. Sometimes it could be a death, which is the end of the admission process. So all that needs to be defined over here. When you say process, I mean to say that your hospital needs to have written, documented processes for each of these. It's not that I'm saying something verbally and people are following it. It's not like that. Everything has to be written as a documented policies and procedures. Transfer process, because some patients need to be transferred to other hospitals. Yesterday, I was talking about stabilization of a patient. So you might be transferring stable patients, you might be transferring unstable patients, you might be transferring in patients who are critical from the site of ailment or injury. So all that has to be covered under the transfer policy and process. Continuity in care basically talks about how you continue care after the admission and discharge is done. So patients coming in for follow-up, patients coming in for repeat admissions, patients who need to be continuously monitored, right? How do we address all of these patients? So that process needs to be defined. The next two important standards are about the lab services and the imaging services. In all the 10 chapters, if you go to see, there is no standalone chapter which talks exclusively about lab or imaging services. Both of these services and the standards related to these services are all incorporated in this first chapter itself. So this lab services and imaging services are quite parallel in the sense that they have similar standards in both. They talk about standardized reporting system, standardized sample collection system, credentialed and privileged doctors who report these tests, whether they are lab or imaging. It talks about, for imaging services, it also talks about radiation safety measures and the statutory regulations that go with the imaging services. It also talks about occupational safety, because there are people exposed to blood, body fluids in the lab, and there are people exposed to radiation in the radiology department. So it talks about occupational safety as well. And then it also talks about some quality measures like internal quality assurance, external quality assurance, and all of that. So this is by and large the gist of the first chapter. The second chapter is probably the biggest chapter in the entire set of 10 chapters. And this is a hardcore clinical chapter. See, if you just see the chapters, I'm just going back to it for a minute. If you just see these chapters, the first 5 chapters are totally clinical. Okay. The 6th chapter is partly clinical and partly this, because safety and quality needs to be applied to all the departments. So this is partly there and partly here. And these 4 chapters, they are mainly non-clinical chapters. Okay, so you can say 60% of our work is clinical and 40% of the work is kind of non-clinical. So coming to the COP chapter, from the name itself, you can make out care of patients, right? So it's a hardcore clinical chapter, which covers all of these standards. There are different standards for each of these uh, care settings. So the first is is a kind of a blanket standard which talks about uniform care of patients. I think yesterday I was referring to this standard, which talks about uniform care. So, uniform care can have several meanings. It can have a meaning of providing care in a uniform way to different kinds of patients, right? Regardless of their caste, creed, religion, status, financial status, educational status, etc., etc. It could also mean uniform care as in standardized care, regardless of whether X is a doctor or Y is a doctor or A is a doctor or B is a doctor. Regardless of who the doctor is, you're providing some kind of standardized care, which is referring to some of the evidence-based guidelines. For example, a person, sustaining myocardial infarction, you will probably refer to the acute coronary syndrome algorithms and the guidelines of American Heart Association, something like that. So when you say care of patients as per standard guidelines, you're referring to the evidence-based guidelines. Now, for certain small ailments, if you really can't identify any standard guidelines, the hospital can certainly go ahead and follow its own devised protocol. But again, the protocol or the process is standardized, it's written, documented, everybody's trained on that, and then everybody follows it in a standardized manner. Then only you can call it as standard guidelines. Okay. Um, Care of patients in a few specific settings. So, for example, in a pandemic, in an epidemic, care of patients who require cardiopulmonary resuscitation, all these different cares, different settings require emergency patient care, right? So how is this emergency care going to be provided is the next standard. So when you talk about emergency care, you'll have to define who is your code blue team, how do you um, announce a code blue, in which cases do you resuscitate, how do you resuscitate, what is the technique to be followed, etc., etc. All of that goes in detail. And then it also involves a setup of the emergency department itself, how the emergency department is designed, how are the triaging areas, and all of that. And all the protocols that you follow within the emergency department. So there are a whole set of standards and objective elements for emergency care. Ambulance services is a separate standard by itself. Could you just excuse me for a minute? I'll just get some water, please. Sorry. Yes. So when you're talking about ambulance services, that is a separate standard. When you're talking about ambulance being called, being maintained, the ambulance driver being able to give BLS if necessary. You're talking about the definition of an EMS team, which consists of a nurse, a doctor, helper, and a set of equipment which can help in the transport of the patients as well as in basic care of the patient during transport. So all this comes in the ambulance services. Nursing care has a separate standard. So nursing care starts right from the way the patient is received, the nursing initial assessment at the time of receiving the patient, then the further reassessments which are done by the nursing staff, then the handover of the nurses, their notes, how they maintain their notes, and some specialized areas which the nurses focus on in terms of conducting audits or in terms of assignment of care and all of that. Care of vulnerable patients, and there are patients with comorbidities and high risk for mortality. So these patients are sort of to be identified so that you can address their issues well in advance before it gets more complicated. So some of these patients could be those who are at a risk of falling, vulnerable patients. Then you have patients with DVT, probability for DVT, deep vein thrombosis. Then you have patients with who require to be restrained. All of these patients have specialized care that is required, because who are these vulnerable patients? They are basically patients who can't care for themselves, right? So special care needs to be provided by the hospital for these patients. There are separate standards for obstetric and pediatric care. So this talks about pregnant women, starting from the antenatal care to the intranatal care and the postnatal care. It also talks about immunization and overall well-being of the baby as well as the mother. Pediatric care could mean just newborn care, or it could mean specialized pediatric care. So again, that will go back to your scope of services. What is your scope? If your scope is just obstetric and newborn care, you can just restrict to that. But if you're talking about high risk obstetrics, then you definitely need to make an NICU also available over there, right? So pediatric care can extend to neonatal care, it can extend to pediatric surgery, it can extend to all the super specialty branches in pediatrics like pediatric cardiology, pediatric nephrology, pediatric neurology. So there's a huge gamut of super specializations, but it all depends upon the scope of services which the organization is offering. And then accordingly, they will be looking at, NABH will be looking at your infrastructure, the manpower behind it, and the processes that you're following. I think herein I have missed out care of critical patients. So that's one standard again here. So I'm just adding that. Care of critical patients is basically ICU care, right? ICU care basically focuses on intensive care. Care of patients needing intensive care. Sorry. Okay. So these are patients who are critically ill. And as I said, there are admission criteria as to when these patients need to get into the ICU, how they need to be monitored in the ICU, how long they should be kept in the ICU, what are the criteria for discharging these patients from the ICU, how do procedures happen in the ICU, how are they supposed to be done, what are the protocols for those procedures, who can do the procedures, how is counseling to be done in the ICU, and so on. Okay. I was here. So care of patients for anesthesia and surgery. So this standard basically refers to the OT and everything that happens within. So right from the infrastructure of the OT, the environmental surveillance, the quality assurance program for the OT, right? It involves how patients are to be cared for pre-surgery, pre-anesthesia, intra-surgery, intra-anesthesia, post-surgery, post-anesthesia. So all of these are different objective elements, okay? In previous days, anesthesia surgery used to be combined together. We used to take common consents for both, but now both are completely streamlined. They're completely different. So there's a separate pre-anesthesia care, which is supposed to be provided by the anesthesiologist, and there's a separate pre-surgical care, which is supposed to be provided by the surgeon. Similarly, intraoperatively, operative anesthesia is separate. The notes of those are separate. Monitoring is separate. And the intraoperative surgical notes are separate. The monitoring is separate. Similarly with the post-op. So these are two parallel but different branches and different protocols for each of these. You can't say that the surgeon has seen the patient, so the anesthetist is not seen, or the anesthesiologist has seen, so the surgeon has not seen the patient preoperatively or postoperatively. That's not acceptable. So both the doctors have to be seeing the patients. Both consents have to be separate. Okay. There is a separate standard that talks about use of blood and blood products. Okay, so rational use of blood and blood products. I think you're aware that these days we don't use whole blood as often as we used to use it before. These days we've moved on to blood products. So we use more of PCVs and FFPs and all of that. What kind of blood are you using? How do you store the blood? How do you indent for the blood? How do you administer blood? How do you dispose the final blood bags? All of that is covered under these standards. There are separate standards there is a separate standard for transplant program, organ transplant program. So depending on if your organization has this or not, you could elaborate on the policies and procedures for the transplant program. All hospitals don't have transplants, so then you can just omit the standard, but whichever hospitals have this, you should elaborate on the kind of transplant that you're doing and the entire policy and procedures therein. Similarly, for research also, organizations conducting research will elaborate on the kind of research they're doing, the methodology therein, and what kind of activities and all the protocols for research would have to be laid down. Policies for end of life care is basically a part and parcel of intensive care because mainly patients in the ICU are the ones who probably would reach the stage of end of life. So how do you counsel these patients, families? How do you make a decision to whether to continue treatment or whether to discharge the patient? Sometimes you might have brain dead patients. So how do you counsel these patients' relatives? Are you going to tell them about organ transplant as a possibility for this dying patient? So all of that needs to be defined under end of life care. There could be also patients suffering from terminal illnesses who cannot be cared for beyond a certain point in the hospital setting. So they might have to be sent back to their homes, and some kind of conventional treatment needs to be, supportive treatment needs to be given in the home front, which might involve training of the family or some assistance in terms of a helper or a nurse assistant or somebody like that may have to be trained to care for these patients. So all that will be bundled under end of life care. The third chapter is management of medication, which is a very, very important chapter, and it's across the organization because medicine is something which is so basic that every patient comes to the hospital to receive medication, right? So if I'm to summarize this chapter in a nutshell, you could just keep in mind the life cycle of a drug. So this standards and the objective elements, they relate to the entry point of the medicine. So how are they procured? How are they purchased? How are they stored? How are they distributed from the pharmacy to the different wards, ICU, OT, ER, and so on? How are they administered? And finally, how are they disposed? Okay. What are the guidelines for prescriptions for indenting the medication or for administration of medication? What are the guidelines for prescriptions? And also, how do you monitor the patient after administration of medication? Okay, so this is the entire life cycle of a medicine from its entry point till the point it is disposed of. Okay. In addition to that, there are some specific standards for some specific kind of medication. One of them being narcotic drugs, the other being chemotherapeutic drugs, and the third being radioactive drugs. Okay, so how do you purchase these drugs? How do you handle them? How do you store them? How do you dispose them? Would have to be different as compared to other drugs, because these are chemotherapeutic drugs are basically cytotoxic drugs. Narcotic drugs come under the NDPS Act, So they are monitored drugs. So their entry point, their consumption, their storage, everything has to be monitored as well as documented, right? Radioactive drugs can cause radio hazards, so they also have to be stored properly, monitored properly, and handled with care. So the storage of all of these medicines has to be identified, proper under lock and key. The stock inside needs to be monitored, and wherever you're disposing it, that also needs to be monitored. Okay. Um, Another few groups of medicines, I can't say medicines, but consumables um, or special devices would be implants, certain medical devices, and consumables. Right? These come under a specific standard because their protocols will be slightly different. Right? You're not going to straight away administer them with a needle or a syringe using, just as you administer any other medication. These come through a different channel. For example, implants may come directly from the company to the operation theater at the request of the surgeon, right? Consumable items are not medicines. They are basically disposable items, okay? Something that can be consumed. So something like your IV sets or catheters, urine bags, you know, all those disposable items could come under consumables. So they have a different protocol to follow because um, you have to be careful about their packing, the sealing. Some of them, in case there are some devices, especially which you're reusing, so those will have a separate protocol. Okay. So, for example, stents or something like that, or dialyzer catheters, which you're reusing, might have a separate protocol for this. So, all that will come under this standard. And there's a separate standard for medical gases. So, again, where are you procuring the medical gases from? Is it from a standardized, authorized, licensed distributor? And then how are you storing those gases? So, there is again an Explosives Act over here, which governs the medical gases. So, there are standard guidelines for storage of these medical gases, and then how do you distribute those medical gases through a centralized system so that the patients get it at their bedside. And you also have compressed air which comes into ventilators which are used in operation theaters and so on. You also have nitrous oxide as gases sometimes. So we use oxygen, nitrous, and carbon dioxide as gases. So you have to have protocols for all of these gases and how you're going to handle them. The next chapter talks about patient rights and education. So, this is where yesterday I said that the patient is the biggest beneficiary for a few reasons. One of them being that NABH is focusing on patient rights and education of the patient and the family. Okay, so as I said way back, nobody was really bothered about whether patient is getting educated or not. But today we have educated patients. We have well-read patients who browse the net, come with a lot of information, and want more. So we should be in a position to answer their questions and also make a joint decision regarding their care plan. Okay. Um, when you talk about protection of rights of the patient, you're also referring to a few vulnerable patients where it is the responsibility of the hospital to take care of the privacy and the dignity of these patients. You're also talking about protecting the rights of patients who are in terminally ill conditions. Um, then there is also consent of patient and relatives. So there's a standard which talks about which conditions you should be taking an informed consent. You know, who are the people who can consent? What about children who cannot consent? What about people who are not in a mental state to consent? So all that needs to be covered in the policy on consent taking. Consent, remember, is a very, very valuable document. It's a medical legal document because it gives you an evidence that you have done something, whatever that thing could have been. It could be a procedure, a small bedside procedure. It could be an operation. It could be a major surgery. It could be anything. So it gives you an evidence that you have taken the consent of the patient to do that procedure or surgery, and it is entirely voluntary, and you have not really applied any force or duress on the patient. So it's a very important medical legal document. Um, Patient and family education could start from something as small as when to come to the hospital, how to follow up, and it can move on to more important things like how to take medication, when to take the medication, before food, after food. It could also involve bigger things like how to care for the patient at home, right? How to care for catheters which are in situ at home. How do you educate the patient about the surgery, about the different benefits of the surgery, the risks involved in the surgery, right? The alternatives for that particular surgery. So all this will come under part of patient and family education. Patient feedback is a very important aspect of care, because we believe that quality can improve when the patient gives us a very genuine feedback of his experience, right? So it's up to the hospital how they want to collect the feedback, in the form of a Google review, or in the form of a feedback form, or in the form of a verbal interview. So whichever way they wish to collect the feedbacks, they could collect it, but it's got to be documented. It's got to be analyzed so that you can understand which are the strong areas of the hospital, which are the weak areas of the hospital, which needs to be worked upon and improved. Okay. Grievance redressal is another important aspect, where we are talking about measures or the methodology to address patients' grievances. So again, a grievance could be anything as silly as, something not being available in the room, a tissue not being available, to a major grievance where they feel that care has not been given properly, treatment has not been appropriate, they want a second opinion, or they don't want a particular doctor, or they don't want to be in the hospital at all. Could be to any level, right? So how is the hospital uh, setting a mechanism to address this grievance? Is there a person who can address the grievance? Is there a cell which can address the grievance? Is there a letter which the a person can write and drop into a Dropbox? What is the mechanism? So that needs to be defined and put into a protocol. Patient communication involves small little reminders that we give, SMS messages, all of that comes under patient communication. The next chapter is infection prevention and control, which is a very vast chapter, very important chapter, because it talks entirely about how you can prevent and control infection in a hospital setting, because you don't want cross infections to happen, right? So for this, we need to have an infection program in the hospital, a hospital infection control program, a hospital infection control committee that works to implementing this program. It talks about elimination of infection related risks, both to patients, to visitors, to staff, to everybody. So how can you eliminate these risks? And what are all the standard precautions to be followed? Something as simple as hand hygiene, moving on to cleaning, disinfection protocols, sterilization protocols, different surveillance activities in the operation theater, in the ICU, in the labor ward, in the ED, in every place. What are the different surveillance activities? What are the protocols for biomedical waste disposal? What is the protocol for needle stick injuries, and how do you give a pre and post prophylaxis for needle stick injuries? That needs to be carved out. Then you have protocols for laundry and linen management, and then an antibiotic policy as to how you can optimally utilize antibiotics. See, why is this coming as part of infection control program? It's primarily coming as part of the infection control program because um, uh, any kind of overuse, underuse, misuse can lead to antibiotic resistance. Once there is antibiotic resistance, organisms are not going to respond to that antibiotic. It may also lead to, worse strains of the microorganism. It can also lead to cross infections. So Just as we say that we are stewards of the environment, we are also stewards of antibiotics. So we have to curtail antibiotics to the best of our ability so as to prevent hospital acquired infections. And the last part talks about the training of the staff in all of these, because these are all hardcore clinical protocols, infection control protocols. They have standard guidelines. They're very specific. You can't deviate this way, that way. And, so the staff need to be trained meticulously on this. The next talks about patient safety and quality. So there has to be a safety program as well as a quality program. There has to be a safety officer and a quality officer. There have to be a quality improvement program, uh, a quality improvement committee, and a safety committee. So these two things are running parallel. If you see this, safety program, quality improvement program, safety committee, quality improvement committee, safety officer, and a quality officer, quality coordinator. Okay, all of these are parallel. What is the job of these committees? That these committees are working towards implementing quality in the hospital. The quality committee is working towards implementing quality in the hospital. The safety committee is working towards implementing the international patient safety goals, the national patient safety goals, right? You're talking about mapping quality indicators, analyzing them, taking corrective and preventive actions. This chapter also talks about incidences. What are the different incidences? What is a sentinel event? What is a near miss? Okay, how do you report this? So, near misses are those incidences where you really haven't caused harm to the patient. Uh, Something is happening and you just prevented it from happening. Okay. Uh, a temporary harm is something that you did wrong, it has caused harm to the patient, but it was temporary. And sentinel event is an error which is either causing death to the patient or it's causing major harm more than 2 weeks to the patient. So these are all different kinds of incidences which need to be reported. So, what is the reporting mechanism? Who is the person, employee supposed to report incidents to? Who takes care of those incidences? Who redresses those incidences or who resolves those incidences? What is the corrective action taken? All that needs to be formulated here. Clinical audits are basically a study of our own clinical treatment, clinical management that we give for our patients. And you map them or match them, compare them with standard guidelines, okay, standard protocols. Okay. And the last point talks about the management support in this quality improvement program. Okay, so management should allocate a budget and support these people who are working towards achieving quality and safety. The next chapter talks about responsibilities of the management. So the management, first of all, should be competent, qualified enough to lead the organization. They should lay out the vision, mission, values of the organization. There should be an organogram which gives us the entire hierarchy of people working therein. The roles and responsibilities of every member within that hierarchy should be defined. And every department which is defined should have a hierarchy within that department. So, who's reporting to who, who's reporting to whom, that hierarchy should be defined. And each of their job roles also should be defined. Then, defining the policies. I told you yesterday about policies, procedures, and processes. So, policies come from the management. So, the management is responsible for releasing those policies time over a period of time, reviewing those policies, modifying them if necessary, and so on. Management is also responsible for all the statutory compliances, licenses, and notifications. The management cannot say that, well, my administrator forgot to renew the hospital license. That's not acceptable. It will be the owners of the organization who would be responsible for this at the end of the day. Okay, so they will be penalized and not the employees. Of course, it's their responsibility to get these things done out of their managing employees. The management is also responsible to support safety and quality programs. And they're supposed to lay out reporting systems, internal as well as external reporting systems. internal as well as external controls. Okay. They're also responsible to establish various hospital committees. There are many committees which are laid down by NABH, such as the Quality Improvement Committee, the Safety Committee, Drug and Therapeutic Committee. You have the um, Medical Practices Committee. You can have the um, Hospital Infection Control Committee, right? You can have a mortality committee. So there are so many committees which the organization expects to have. And establishing these committees, identifying people who would be a core part of the committee, and monitoring all their activities is also a part of the responsibilities of management. The next chapter is facility management and safety, which is a non-medical, non-clinical chapter, which talks about the equipment in the hospital, both biomedical as well as non-medical equipment of the hospital. So how are we going to purchase these equipment? What is the protocol for purchasing? How do you maintain the equipment? What is the operational plan for the equipment? And in case of a breakdown, how are we going to handle that? In case the equipment has become redundant, how are you going to replace that? How are you going to dispose that? All that will come under this chapter. Besides that, it also talks about the safety of the infrastructure itself. So the safety committee is expected to take safety rounds, make sure that the infrastructure is safe for patients, relatives, and staff. It's got to be environment friendly. You can make it energy efficient by reusing, recycling material and stuff. It also talks about safe water, safe electricity, safe utilities, basically. All utilities should be safe. And safety from fire and non-fire emergencies. So this chapter talks about all the conducting the mock drills, the emergency codes for the hospital, uh, code blue, code red, code yellow, and all of those emergencies. So how do you train people on preparedness for these emergency situations and so on? The next chapter talks about human resources. So again, just like I told you the life cycle of a medicine for MOM, in this chapter HRM, you can think about the life cycle of an employee. So how is the recruitment mechanism of an employee? How do you plan how many people you require in each department? So it starts from there, actually. It starts from HR planning, human resource planning. Okay, how do you plan how many people should be there in each department? What should be their job responsibilities? What should be their qualifications? Okay, all that needs to be decided first, the selection criteria. And then you recruit people. So people come into the organization. Once you have employees, you train them, you develop them professionally, you help to enhance their skills. Okay. And then you appraise them. There should be a performance appraisal system, which is appraising people's performance. And then you have a facility to take or a methodology to take disciplinary actions. What is the mechanism for that? In case employees have any grievances, what is the mechanism to address that? Do you have an internal complaints committee which addresses employee grievances? Okay. Then this chapter also talks about the rights and the responsibilities of employees, just like we spoke about rights and responsibilities of the patient. Here it talks about rights and responsibilities of employees. Okay. It's also the responsibility of the organization to check employee satisfaction periodically. Okay. So you try to cater to their health needs, either by giving them a vaccination or by doing an annual medical checkup. Okay. There is also one standard which talks about credentialing and privileging of doctors, nurses, and allied professionals. So this is nothing but the qualification and the privileges given to doctors and nurses and allied professionals to do specific things. Okay, for example, every surgeon may not practice laparoscopy. Okay, maybe the old timers may not be doing laparoscopy. So if you have a specific qualification for laparoscopy, then only you can do laparoscopy. So that's a credential, a qualification, and a privilege, which is a right given to the doctor because of his credentials. Okay. Statutory compliances in HRM are also there. So the provident funds, ESIS, and leaves, and welfare benefit, maternity benefit, and so many other statutory compliances are there. The last chapter talks about information management systems, which is all related to medical records. Medical records could be manual, medical records could be electronic, you have EMR as well. So, what is the policy for identifying the author of entry? That's the most important thing. Who has written the medical record? Who has entered it in the EMR? Right? That's the most important policy that you need to frame. Completeness of medical records. Are these medical records complete? How do you secure them? Where do you store them securely? Okay. Integrity of the records. So it's our responsibility to make sure that these records are intact and you don't lose pages here and there, or you don't lose the record itself, right? And all the notes written there are in chronological order and they are kept properly. Confidentiality of records is a patient right. It's a right of the patient that his record is not shared with anybody, right? So how are you going to maintain that confidentiality? You have to create a policy for that. Restricted access to medical records. Okay. So anybody and everybody cannot come and take charge of the medical records. It's the property of the hospital alone. And if the patient himself asks for a copy of it, we are allowed to give an attested copy, but not to anybody and everybody else. So in case the patient is sending his relative to collect the records, we have to make sure that the patient has given a consent to collect the medical records. Okay. Then how long are we going to keep the records? We can't keep it for a lifetime. So according to standard guidelines, we keep OP records for 3 years, IP records for 5 years, MLC records till the case is over or for a lifetime, birth records for 21 years. So all these are standard guidelines. Similarly, what is the policy for destruction of records at the end of the retention period? How would you destroy records? How do you analyze these medical records? In case you're doing a medical audit or a clinical audit, you would use these medical records. So how do you use them? Who can access them? How is the analysis made? What is the outcome of the analysis? All that needs to be mentioned. What is the support of the HMIS system, the Hospital Management Information System? How does it support electronic medical records? And how do you maintain the database? How do you protect the server? You have an external one, you have an internal one. How is it? And are we contributing to any external databases? For example, maybe any pharmacovigilance department, or we are contributing to the Pune Municipal Corporation for collection of some mortality or infectious diseases. All of that will come as external database. Okay. So this is about the hospital management, information management system. This was the last chapter. And I'll just conclude by giving you a quick idea of the accreditation process. So the accreditation process basically starts from putting in an application online for the accreditation. You should choose your level. You should choose the nature of your organization, whether it's SHCO or HCO, and then put in an application. Once the application is registered, you get in a registration number, and then there is an appointment of an assessor. There is a pre-assessment, which is like a desk assessment, which means that all the documents that you uploaded online are first assessed, and then non-compliances are pulled out from that. Those non-compliances come back to us, and then you have to close those non-compliances. You're giving 2 chances to close the non-compliances. And then you come to a final assessment. At the final assessment, there is a scrutiny of the assessment report which is done. The final assessment, of course, is an on-site assessment. So people will come, assessors will come physically. They take a round of the hospitals. They interview the staff. They can interview the patients. They interview the doctors, the consultants, right? And they look at all the implementation of all the standards. And then finally, they create their report online. This report is further scrutinized by the accreditation committee, which does not have anything to do with the assessors. The panel of assessors are different. The accreditation committee is different. So the accreditation committee will just scrutinize the reports of the assessors, and if they have any further queries, they are free to ask the hospital those queries. And if they don't have any queries, then they will just close the report and go ahead and issue the certification. So this is the entire loop, and this whole loop generally takes about anything between 8 months to 12 months for the whole thing to happen. Entry level is probably slightly faster. The full accreditation preparation time itself is quite long, so it takes a little more time. So that's about NABH accreditation. I think I have covered most of the information that I wanted to give you. So if you have any questions for me, I'm happy to answer them now. Yeah, please unmute yourself and then you can ask me the question, or you can put your questions on the chat.
Pradeep sir, I guess student can unmute themselves, right? Kindly allow them to unmute.
Yes, ma'am. I am allowing them.
Yeah, kindly allow them to unmute.
Can we get any book of NABH? Yes, of course. You can purchase it online.
Thank you so much for your guidance. Thank you so much.
Yeah, most welcome.
Thank you so much, ma'am. It was well articulated, and there are lots of very new information for us. But I have a question. This is very important for the patient side.
Yes.
So all about you talk, that was the center to care the patient and their quality. But the thing is, standardized format of the bills, which will be applicable to the hospital. The NABH accreditation has not mentioned in their instructions how they are going to approve in this point, then because the format will require them to provide the clear and itemized broken all the charges, right?
Yes. So
But,
see,
but we have experienced a lot in the hospitals that there are many charges they have written just other charges, which is not itemized. So
right.
What is the procedure for the NABH about this billing department?
Yes, I'll answer your question. So NABH, as I told you right from the start, focuses only on two things, that is safety and quality of care. Okay, it does not focus on the commercial aspect of care at all. There are just about one or two objective elements which talk about the commercial aspect of it. One of the objective element just says that the hospital should have a standardized tariff. That's all. Now, how much to charge, that NABH cannot comment. For that matter, what process to implement, that also NABH does not comment on. It just gives you a broad outline that you should have a process like this. That's all. It does not tell you that you should have a process like this, exactly 1, 2, 3, 4, 5. Does not give you any specifics like that. So same applies to billing. It just says you should have a standardized tariff, which means that all patients should have the similar tariff. Now, the hospital might say that, ma'am, how can you have a standardized tariff? CGHS patient will have different tariff. PPN patients will have different tariff. Private insurance, different tariff. Cash patients, different tariff. Yes, I agree. So you can have different tariffs, but it should be standardized among that section.
All
so
right.
You say there is a standardized tariff for cash patients. All cash patients should have a similar tariff. And of course, it's got to be itemized, which includes the doctor's charges, the bed charges, the nursing charges, the equipment charges, the medication charges, the procedure charges, and all of that.
Yeah, got it. Thank you.
Yeah. Any other question?
No, ma. Thank you so much, ma. Thank you so much.
Yes, thank you so much. So should we wind up then? Tanika ma'am, can we wind up?
Yes, ma'am. If there are no more queries, we can
Yes.
conclude the session. Students, please kindly fill in feedback form.
Yeah. So if there are no questions, we can wind up the
Ma'am,
session. Thank you for
this PPT will be provided through the email.
Recording will be available.
Yeah.
All right.
Yes.
Okay. Yeah. Thank you. Thank you all for joining.
Okay, bye.
Thank you so much.